Hi, Erin. My name is Emily, and I was assigned to do your peer review for your video. I just wanted to start by saying I thought you did a really, really good job. I liked how you started by doing an overview and explaining what each part of the exam was first, and then you went more in depth into each part and showed normal versus abnormal findings of it. I have to say I was a little bit nervous at first that you weren't doing the exam on another person. And I don't know how you did it, but you did such a good job of both showing how to perform the exam and also showing what your patient should look like while you're doing the exam and showing the normal findings versus abnormal findings and explaining what they could reveal. I know for me, I find it really important to know what someone's baseline is. So if I come in the morning and I'm getting a report and I hear that my patient had a CVA in the past, I'm always asking if they have any sort of residual from that, so I know to expect when I walk in the room. And if there's anything off from that, I know to be concerned. I actually did my project on the mental status exam, which you also showed in your neurological exam. It definitely is part of the neurological exam, although a neurological exam, I guess, isn't really part of the mental status exam. So I work in oncology, and we perform pretty basic neurological exams on some of our patients. So I'm not super familiar with some of the more in-depth parts of the neuro exam, so I definitely did learn some new assessment skills from your video, so thank you. So in oncology, many of the chemotherapy drugs that we use actually have some neurological side effects associated with them, and they can range in severity. And it also depends on what regimen it is, and the same drugs, depending on what dose they are, they could have no really neurological effects or pretty mild ones, or pretty severe, kind of depending on the regimen, the drug, the dosing, all of that. So for example, with our acute myeloid leukemics, once we get them into remission, we keep them in remission through what's called consolidation chemo. And it's typically, we use a regimen called HiDAC, which is just high-dose cytarabine. And high doses of cytarabine are associated with neurological adverse effects. So we watch these patients really closely. As part of our assessment of them, we do what's called a chemo neurotoxicity exam. So we get a baseline, and then we perform this exam every time that we give them the drug. So one of the things that we do is we have them touch their fingertips to their thumb back and forth, and then we'll have them close their eyes and reach their hands out, and they have to touch their nose. We have them walk to assess their gait, and then if they are able to, without falling, because nobody wants that, we'll have them stand on one leg and then take the opposite leg and run their foot down the shin of the leg that they're standing on. We also typically keep a signature log in their chart, so we have them sign their name on a piece of paper every time that they get the drug, and then it helps us to see. That's a way to visually see too and keep track of if over time if there's any neurological changes. Another common reason why we perform neurological exams in our oncology patients is in our patients with brain mets. Brain mets can be pretty scary in that you can have them and not know, and then all of a sudden they can have severe effects on the person just like that. So any person that we know has brain mets that were found on a PET scan or a CAT scan or something like that, we typically do Q4 neuros on. And also patients that have any involvement along their spine, so like any extensive bony mets along their spine, We tend to do Q4 neuros on as well because those patients can be at a high risk of spinal cord compression, which has a high mortality rate associated with it and is considered an oncologic emergency. And actually to treat both of those, both brain mets and spinal cord compression, we use high doses of steroids, typically IV Decadron, and then we switch it to PO, and they actually go home on these high doses of steroids as well. And these patients also often receive a course of radiation therapy, which is really, really good at shrinking these types of tumors. So thank you so much for sharing your video. I learned a lot from it, and I hope you learned a little bit from mine. Thanks.